started. So let me introduce myself. My name is Adrian Lasmana. I'm one of the assistant professor in molecular medicine at Cleveland Clinic Lerner College of Medicine. And I would like to welcome everyone to the CIS October KISS conference. And this webinar is sponsored by the Clinical Immunology Society from the Early Career Immunologists, or ECI committee. And to remind everyone that if you are a trainee, either in residency or in fellowship, membership for Clinical Immunology Society is completely free. So feel free to join us. You can apply directly by logging into the website, the CIS website. I also would like to remind everyone that we would like to be as interactive as possible during this webinar. So we will stop the presentation at several points, and we will ask some audience participations, and you can use the chat function to ask questions or put your comments. So for tonight's October KISS conference, we are lucky to be joined by Dr. Roshini Abraham. So Dr. Abraham is a professor of clinical pathology and also the director of diagnostic immunology lab at Nationwide Children's Hospital. And she will be our senior mentor for both cases for tonight. And for the first case, it will be presented by Dr. Nicholas Klein, who is currently a clinical fellow in allergy immunology at Cleveland Clinic. So I will hand it over to Dr. Klein.
All right, thank you. Let me go ahead and share my screen here. All right, yeah, my name is Nick Klein. I'm one of the second-year allergy immunology fellows at the Cleveland Clinic. Kind of similar, we have this title here about a pretty interesting case we saw over the last couple of months. So kind of like Transformers-esque, more than meets the eye, looking beyond the DHR test. So let's just go ahead and kind of get started because I know want to have plenty of time for discussion. So some of the learning objectives just kind of up front. DHR testing may not be adequate to detect some cases of CGD, which is kind of terrifying. But so new variants leading to presentations concerning for CGD are being discovered throughout the literature. And then the last one is genetic testing should be sent for patients in whom there is a strong clinical suspicion. And so those are the big learning objectives from today. This is kind of a timeline of events. So I'm just going to go through where we saw the patient was over here, kind of further down the timeline, but I think it's best kind of presented in chronological order. So we'll kind of start over here back in 2015 when the patient was around 4 years old, starting at Mayo. So this is all history prior to being seen by us at CCF, and a lot of the stuff we didn't know at the time. But anyway, so she was 4 years old at the time, was the offspring of consanguineous parents. She was born full term, had some developmental delays. Whoop. Hold on just a second. Sorry, I got signed out. Let's go to this one. Okay. Let's go back. So had some developmental delays in cognitive speech and motor skills. So at 4 years old, she had 4 hospitalizations at Mayo Clinic with 2 episodes of severe pneumonia in the ICU, requiring ICU admission. So some of the initial admissions were milder infections with low O2, but then it progressed to more difficult to treat pneumonias. There was no history of infections outside of pneumonia, so no skin, soft tissue infections, endocarditis, meningitis, those kind of things. She was admitted to the ICU with severe upper lobe pneumonia, had CT at the time, which showed bronchiectasis. And due to that, they elected to check sweat chloride, kind of thinking more cystic fibrosis. And so that was within range. And then she was a potential heterozygous CFTHR carrier. They tried to perform a nasal biopsy, but the sample was inadequate. But they elected to deem cystic fibrosis was very unlikely. Later on during that admission, or during some of the admissions, they had found in the patient's BAL, she had some typical kind of CGD organisms, the most typical of which is the Burkholderia and Serratia marcescens. That's what kind of led them down this road of, could this be CGD? So this is kind of the big thing that I'll focus on. But so she was evaluated with the DHR testing, which was actually low normal, and then ultimately got whole exome sequencing, which we didn't know this at the time we saw her earlier this year, but it revealed as this variant of unknown significance. So she had a homozygous missense mutation in the CYBA gene, which was encoding for this P22 FOX protein. So some of you may be like, what is this? So we'll kind of get into some of this later. Dr. Abraham prepared a nice slide, which kind of goes into that. But so the parents were heterozygous for this variant, and then the patient did have a couple of siblings, and one of the sisters was tested and did not have this variant. So this is another just kind of their kind of initial testing they've done at Mayo. So this is a DHR test, and we later found out that there was actually a paper published on this patient. So this was pulled from that paper, but this is just testing the patient's DHR test versus a healthy donor versus the patient's father. So what we're looking at here is you have these kind of histograms, and then this red kind of histogram, you have the unstimulated portion, and then they're stimulated with this PMA, and then that's where you have this kind of this transition to this green peak, which is usually normal. You should have this nice transition, but it's measured in this MFI. So an MFI in this particular laboratory greater than 60 was considered normal. So this is our healthy donors, MFI of 130. The father had an MFI of 158, and then the patient had an MFI of 74. So still above 60 and normal, but kind of in that low normal range. They actually repeated it twice more, according to when we got the outside documents, and it was 65 and then 121 respectively. So still normal and quite a bit of variability. They also checked the NBT, which is another test, as everyone knows, it's kind of like an older school test beyond the DHR, and that was also normal. So they kind of did some further testing too. So this was all new to me and things I hadn't heard of, but things that are pretty cool. So these are a number of different panels, which is just where they're testing the patient sample, the father and the mother, with different types of stimulants. So we have our PMA, which is kind of part of our DHR. So I think a good place to start is probably here. So this is kind of like our DHR stem, and we can kind of see the patient is in red, and then we have the father in yellow, the mother in purple, and then the healthy volunteer in green. So everybody is about the same as far as PMA causing stimulation. However, if we look to this FMLF kind of stimulating agent, we see quite a drop off in the patient sample, but all the other samples were kind of up here in this other sort of peak. So a little bit suggestive of some decreased oxidative activity. And the same thing here, this OP zymosin, this is just kind of a different stimulating agent. This is something I just kind of learned about over the last couple of months, but you can see that the red, which represents the patients, there's a little bit of a drop off when you compare the mother, father, and the healthy volunteer. So we're seeing a little bit of this, kind of contradicting the DHR test in that we're having a little bit evidence of decreased oxidative burst activity. And then this is just looking at those particular proteins. So
Nick,
go ahead.
Sorry. Do you just want to go back for a second? So just a couple of points to make. The P22 FOX is co-expressed along with the GP91 FOX on the phagosomal membrane. The GP91 is our more familiar X-linked CGD. And then the P22 interacts with P47, P67, the other subunits as well. And so when we use luminol, it's meant to look at these reactive oxygen species or ROS. Luminol is cell permeable, so it looks at ROS at the plasma membrane as well as at the phagosomal ROS. And if you add superoxide dismutase, then what you do is you quench the plasma membrane ROS and you wind up looking at only the intracellular ROS. So the point that Nick was trying to make is that sometimes, depending on what you're using to stimulate your neutrophils with, you can get different results. And PMA is the least physiological, and it's sort of, the equivalent of a PHA in a proliferation assay, a sort of a sledgehammer. The opsonized zymosin and the FMLP is what many of us say. It's the same as FMLF. Particularly FMLP, has a much weaker NADPH activity, much weaker DHR response, but that's where you can really sort of tease out the difference between the patient and her parents. And then the bar graph at the bottom is where we used a heterologous expression system using COS7 cells. It's an African green monkey fibroblast cell line, and we transfected it with wild type P22 or the patient's mutation, or we used what we call the V5 tag. It's a 14 amino acid peptide tag from the paramyxovirus. And what you can see is that the orange is the mutant, either with the V5 tag, where Nick is holding his arrow, or without the V5 tag, which is the second orange bar that you see over there. And it's lower than wild type, but you see that the V5 somehow stabilizes it. There's a 25% difference in the ROS production between the mutant with the V5 tag and without it. So that means that there's some instability to the protein as a result of that mutation that this patient has. Yeah, go ahead, Nick.
Oh, yeah, perfect. Thank you so much. This is just kind of what Dr. Abraham was talking about. So there's actually a nice picture on the next slide, but this is just looking at the different protein expression levels. But as we'll see in the next slide, the GP91 and P22 FOX, they're kind of co-expressed, or they're expressed together in the membrane, so they help kind of stabilize each other. So we know this patient, this particular variant was leading to alterations in that P22 FOX. So we can see just here the amount of expression of this P22 FOX is depressed in the patient versus the father, mother, and the normal controls. And then also this GP91, but we know there wasn't a variant in that particular gene for the GP91, but just because those two are associated with each other in the membrane, we see those depressed levels. And then this is just kind of over here in A and B, just showing kind of histograms of that using that same MFI values that we look at. So we see this decreased amount of expression or numbers in the patient compared with the donors and the father and mother. They even go on to mention in the paper, I believe, that the fathers and mothers are a little bit depressed when compared to the donors. And then if we look down here, this is this GP91 expression. We see the patient's red histogram here is a little bit less than the parents, and then healthy donors. But if we look at the healthy donors, it's quite a bit higher than both the father and the mother, and then much higher than the patients. So was there anything to add about this one, Dr. Abraham?
No, I think you covered that very well. Thank you.
Perfect. And then this is the figure we were kind of talking about, but I'll just kind of go over this a little bit. And then I think Dr. Abraham prepared this slide, so I don't want to steal her thunder, but we can kind of see, like, in the membrane, this is this GP91 and the P22 FOX. So you can see this kind of close relationship and how they're both inside the membrane. And it's just all part of a complex of multi subunits. So it's not just one giant protein sitting in there. It's a lot of other helpers that are helping out. So you can have different variants potentially in any of these different subunits leading to abnormalities. But I'm sorry, I don't mean to take your thunder there. I know you made this slide. So
no problem at all. I think you covered that. The only point to make is, P22 FOX CGD accounts for about 6% of CGD cases, and most of the mutants described with P22 FOX CYBA aggregate protein expression. So there are very few that retain protein expression. There's another one, proline 156 to glutamine, if I recall correctly, that also retains, but abrogates the ability of P22 FOX to bind to the P47 NCF1. So this is another example of a CYBA variant where protein expression is somewhat preserved, in contrast to others where it's completely lost.
Perfect. And then kind of moving on. So this is the assessment plan that was initially performed at Mayo. So this may be a good just kind of get everyone's thoughts and if anyone has any ideas. But given that the patient had this other detailed testing, which showed potential abnormalities in the respiratory burst, but normal DHR testing. So taken together with this extra testing showing some objective data, plus the objective data of the BAL showing serratia and Burkholderia, they elected to start prophylaxis at the time with Bactrim and voriconazole, and because it was very suggestive of a diagnosis of CGD. So does anybody have any thoughts on this or do anything differently?
So I guess in line with that questions that Nick proposed, I think there's a question in the chat as well, like what is the availability of this testing? You know, we all use DHR as our initial screening testing. You know, in the past we used NBT and then kind of replaced by DHR. Can you comment, Dr. Abraham, on the availability of this type of testing and when should we start thinking along this line of testing in our patients?
Yeah, thanks, Adrian. I was trying to type, but I'm not fast enough. So we do offer this panel. Currently, it has 4 proteins, GP91, P22, P47, P67, and we plan to optimize P40 and EROS. It is in our development and validation pipeline. Currently, we do it offline whenever anybody has need of it. Offline means free of cost. And so I found it to be tremendously helpful for, you know, tricky DHR cases, tricky phenotypic cases where, you know, the phenotype is not classic for CGD and the DHR is a bit iffy or the DHR is abnormal. And it's particularly useful for NCF1 because you know that NCF1 is not on the Invitae PID panel, it's on the GeneDx panel, which really looks at the more common 2 base pair delta GT deletion. But this is a very rapid assay, and I think Amrita, my R&D scientist, is on this webinar as well, and Amrita is working on optimizing and validating this panel to bring it up clinically. So I think for the P47, we turn it around within a day. So you'll never get genetic testing results in a day, but within a day, we can tell you which way the wind is blowing. We do also offer ROS testing through a colleague of mine who's in our research institute that's done purely on a research basis, looking at ROS, intracellular and extracellular ROS. But we do that for those sort of tricky cases, whereas the NADPH oxidase panel is really going to come into the clinical sort of testing repertoire. We just have a long list, so we have to prioritize and work our way through it. But the ROS assays will never come into the clinical just because of a variety of analytically complex things, but those are available on a research basis. So hopefully that answered that question, Adrian.
Yeah, and you probably need to move forward, Nick, so I know you have a few more slides.
Okay. So just kind of moving forward in the timeline of events. So here we are now in 2023. So we have all this that transpired in 2015. Kind of get into this, but it mentions in a note from 2019 that the patient had been on prophylaxis for 2 years. And this was a note from an immunologist in Kuwait. So tagging it somewhere maybe around 2017 as best I can tell. And then it was later discontinued by this immunologist in Kuwait because they had repeated the DHR testing and that testing was normal. And so they elected to discontinue it. But so we're now in fellow clinic. This is just kind of everything that happened in the meantime. They had went back to Kuwait in the meantime and then had the prophylaxis discontinued after about 2 years of being on the therapy. And then when she saw us, she had no further hospitalizations or ICU stays since being off the prophylaxis. So that was reassuring. They did state that she was getting respiratory infections requiring antibiotics roughly once per month per their report. and most of those symptoms were manifested by cough. When they were on prophylaxis, they had mentioned that it was a lot less frequent, so like twice a year during that 2-year period. And then between the episodes, like when she would receive antibiotics, she would feel a lot better. They didn't culture any of those, as far as I'm aware. They would just hand her antibiotics, and then continue to have no other infectious sources outside of respiratory. Continue to have issues with dysphagia and monoclonic epilepsy. Just kind of quickly about medical history. So did have epilepsy, developmental delay. These recurrent pulmonary infections, growth hormone deficiency, and chronic aspiration. As far as surgery, she had a G-tube placed in 2015. No known drug allergies. Medications were anti-epileptic drugs. And then she did have albuterol nebulizer and Proventil to use during times of that kind of cough when she would have her episodes. As far as family history, the parents were consanguineous, so that's important. But the mother had asthma, otherwise healthy. The father was healthy. She had 4 siblings, and I think she was the youngest of which, but was the only one that was unfortunate enough to have kind of this stuff going on. But one other sister with seizures and lung inflammation, but no infection history. Physical exam, just kind of speeding through this, was pretty unremarkable as far as vitals. She did have a short stature, no like clear dysmorphic facial features, and then was nonverbal, otherwise normal. So at the time, we didn't have the records from Mayo Clinic. Things on our differential, there was one note from Kuwait that mentioned this CGD that was diagnosed at Mayo. So that's how we knew to track down those records. But our differential was, could this be CGD? Could she have some kind of humoral immune deficiency given her recurrent pulmonary infections? Was this due to chronic aspiration, asthma, cystic fibrosis, or were there other considerations? So our plan, because we didn't have all the information, was to hold off on antimicrobial therapy with prophylaxis at the time, wait till we get more information. She's been doing otherwise well for 4 years. Recheck the DHR, check a humoral immunity panel, lymphocyte flow, get genetics involved, try to obtain the records, check a chest x-ray, follow up with POEM, which they had already had a POEM appointment on the books, and then follow up in 3 weeks because we wanted to kind of get the ball rolling while they were still here in the United States because their plan was to go back to Kuwait. So this is the chest x-ray. I'm not a radiologist, but it does mention left lower lobe bronchiectasis and peribronchial thickening, and then some pulmonary nodules. So we talked with pulmonology kind of behind the scenes and elected to get a CT. And here, this one I can't actually see, but you can see the bronchiectasis and peribronchial thickening in this left lower lobe. As far as other labs, so immunoglobulins looked great. All those were within normal range. The patient had a normal DHR, so we can kind of see that same kind of testing here, but you can see the patient sample compared with the client submitted control. And you see this kind of before and then after activation with the PMA. And we see this, 95% activated cells. And then over here, it again looks adequate. So repeat DHR and everything looked good from that regard. And then as far as the flow cytometry or immunodeficiency CDC, lymphocyte counts, including T and B lymphocytes and NK cells, were all adequate. So she was later seen by genetics, and then the testing for that was repeated because we didn't have a lot of the records at the time, but it again showed this autosomal recessive, very uncertain significance in the CYBA gene. And then when she was seen later, so we're kind of getting to the end here, was seen later, about a month or so. She was continuing to do well. They were very anxious to return to Kuwait. And then what we elected to do ultimately was to restart the prophylaxis, given that we now had all this other evidence of some low normal DHR, some other testing, some altered protein levels, and as well as the uptick she had in infections that were occurring kind of more on a monthly basis versus twice a year. We thought it was best just to go ahead and restart it. I don't know what the right answer is, honestly, but this is what we elected to do. And so we restarted Bactrim and itraconazole using the liquid form, giving her dysphagia. And then the family did see pulmonology later, and they had suggested the current symptoms may be related to chronic aspiration or bronchiectasis. But again, it's hard to tell, especially with all the extra information we had from Mayo, what the right answer was going forward. But so that's what we elected to do. As far as the key teaching points, just kind of quickly. So DHR testing may not be adequate to detect some cases of CGD. So again, it was a great learning point for myself. New variants. So this was like the first time we had seen this particular variant. So new variants leading to presentations concerning for CGD are being discovered. So keep that in mind too. And then if you have someone that, you check the DHR, you check this testing and things don't really seem to add up, it may be time to consider, further genetic testing to try to determine, is this something new? We can help turn these variants of uncertain significance into, something we can now potentially write up or tag to a set of clinical features. So that's about all I have. But so yeah.
Yeah, excellent. I think we have a few more minutes to address some of the questions from the attendees here. I think you kind of touch on this a little bit, like someone mentioning about the early bronchiectasis in this patient seems a little bit unusual, especially in the absence of typical other infection that you could see in CGD patient with the cutaneous or skin infection or other infections. So there might be some other processes that going on, and I think you kind of addressed that a little bit. And this patient also has probably some underlying neurological disorders. I think Nick mentioned a little bit earlier in your slide, there's an additional VUSs that is suspicious for explaining the myoclonic epilepsy. So maybe during those intractable epilepsy, there's multiple episodes of aspiration that probably explaining some of the early bronchiectasis findings that we see in these patients. And then in regards to this particular CYBA, Dr. Abraham, would you expect, since this is more hypomorphic kind of function, do you expect this type of severity of clinical presentation, or would you agree with the other people suspicion there might be some additional processes going on?
Yeah, as I mentioned in the chat, I was misled initially till we got the BAL and the trach aspirate cultures back, and so that's why I called the patient back and asked the father to come along to repeat the DHR. Got the same results. I remember talking to Steve Holland at the time about this, and I said to Steve, have you ever come across a situation where there is apparently normal DHR, but the patient has, organisms that are classic for CGD? And he said to me at the time, I'm quite certain this is CGD. I've not come across a situation like this before, but I think that the organisms are telling us something and we need to investigate it further. And at that time, we had sent the exome, to our research group. And then, when we got the result back, all the dots sort of started coming together. But, till before this patient, after, signing out so many DHRs, a few thousand a year, I had never come across a situation like this. So I guess the moral of the story is you can never say never. Because there'll be a patient who comes to prove you wrong and who can look atypical. We had a boy with hypomorphic X-linked CGD with only Burkholderia pneumonia, one episode at age 7, otherwise healthy, no other things. But he had abnormal DHR, but only partially. So he looked like a complete myeloperoxidase deficiency or a P40 FOX, and he only had one clinical episode. So I've told other people that, looking at the pattern of the DHR can sometimes help you make some correlations with the genotype. And sometimes people can misinterpret the DHR data, particularly with the hypomorphic variants, if they're not experienced. So always ask for the DHR flow data, so you can take a look at it yourself and not totally rely on a pathologist or a hematopathologist to necessarily be able to interpret the nuances.
Thank you, Dr. Abraham. I think that's an excellent key teaching point from this case. For interest of time, I know there are a few more questions. I think Dr. Abraham can continue addressing some of the lab-related questions, but we can move on to the next case. So I will hand it over to our next moderator, Juanita.
Thank you. And thank you all for this wonderful case. And Dr. Abraham, it was wonderful, all your insight. Thank you so much. And thank you everyone for joining us. This is amazing to have this interesting cases. And thank you for your participation. It's wonderful to see all your great questions, and please keep them coming. We want to make this absolutely interactive. So please do continue asking all our questions. We'll try our best to keep track, and if not, make sure to answer them offline. Now, for everyone who has joined us tonight, we want to remind you that if any of you have encountered or participated in a case that you want to share, either recommend or present yourself, we want you to please send it our way into the CIS info box. I'm going to send the email at which you can send it. We would love to hear from you. So please send it our way. And then before we move on, I want to present the next presenter. His name is Adil Khan. He's a second-year fellow from LSU Shreveport. And we have a case today that is titled Autoimmunity Beyond Rheumatology. So I'll let you start.
All right. Are you guys able to hear me?
Yes, perfect.
Thank you, Dr. Valdez. I would like to thank you, Dr. Valdez and Dr. Ibrahim, who have helped me with this presentation. So starting off with our case, autoimmunity beyond rheumatology, I just want to give you guys a background about this patient. This patient was seeing rheumatology for some time before she presented to an outside allergist and ultimately was referred to us. So I wanted to make this a bit more interactive. So let's start there. So we have a 33-year-old Caucasian female who was referred to our clinic from an outside facility with past medical history of atopic derm, had several years of history of hair loss, dry eyes, and mouth. And recently, she was being worked up for iron deficiency anemia and was having recurrent infections for the past year. Also, she today mentioned she came to our clinic today for a follow-up that she is also being worked up for a pelvic mass. So we took more detail about the immune history, and she mentioned that she had 3 sinus infections over the past year, had 1 pneumonia, not sure if it was viral or bacterial, had 5 to 6 courses of antibiotics along with steroid courses over the past year. And then going into her autoimmune history, we found out that she was diagnosed with Sjogren's back in 2012 and alopecia totalis back in 2016. Some other points in the history: she had a hysterectomy, appendectomy, and cholecystectomy. Family history was significant for father with history of rheumatoid arthritis. Maternal grandmother had a history of lupus nephritis, and she mentioned that paternal grandmother also has several autoimmune diseases, but they're not on good terms, so she didn't know much. So on exam, she was vitally stable. She didn't have any hair on the scalp. She had bilateral eczema on the arms. And then with her permission, we took some pictures, and as you can see, she has some eczematous rash. And then as you can see, that we have no hair on the scalp. So at this point, if you guys are presented with something, what comes to mind?
So Rebecca Mars is actually asking what the steroids were given for. Well, you guys add your differential diagnosis in the chat. The steroids were mainly given for sinus infection along with antibiotic courses.
I don't think I'm able to see the questions though. Maybe my view has changed. Let me see if I can fix it. All right, so I don't think I'm able to see the chat.
Okay, so evolving CVID.
Okay, there it is.
There you go. SOX1
So,
haploinsufficiency.
Evolving CVID, yes, that's something that comes to mind. CS1 haploinsufficiency, and then I think there's an answer from Dr. Abraham about the last presentation. So moving on, that's CVID was on the top of the list. It could have been a specific antibody deficiency, HIV, complement deficiency. So most of the labs, they were already done by the outside physician who had referred this patient to us. So as you can see, all the CD3, CD4, CD8, they were all normal. The only thing we could really see was the hemoglobin slightly being low, but this is after transfusions. She had a couple of transfusions as well for the anemia she was having. Then if you look at on the right side, all the immunoglobulin levels, they were low. IgE less than 2, A16, G261, M23. Moving on, so unfortunately, we weren't able to get a post-vaccination, or rather, we weren't able to vaccinate the patient because she was on IVIG. But this is what came with the referral. And as you can see, all the pneumococcal titers were basically non-existent. On the other side, we did have response to diphtheria, tetanus, and hemophilus, and the complement level was low. So now what we are thinking and what should be the next step, ideally.
Okay, so they have mentioned NF-kappa B2, LRBA, and CTLA haplo, RAG, STAT3, gain of function. CTLA4 here could be suggestive of Evans syndrome with the anemia. Awesome.
Yeah. All right. So moving on, we obviously, when the patient came to us, we got the genetic panel. So we found out that the patient had different mutations. More importantly, she had a CTLA4 mutation at the on intron 1, and they said it was likely pathogenic. So this mutation hasn't been seen with CVID yet. Then she had some other mutations as well, one of them being LIST, which we typically, our patient didn't have any clinical signs and symptoms that we typically see with LIST. And with NBAs, we see in infants with liver failure, but obviously our patient is in her 30s. So moving on, so this is what usually comes with the Invitae genetic panel. As mentioned, it affects the acceptor splice site in intron 1 of the CTLA4 gene. It is expected to disrupt the RNA splicing. Variants that disrupt the donor or acceptor splice site typically lead to a loss of protein function. And loss of function variants in CTLA4 are known to be pathogenic. This variant is not present in the population database. So that's why we are bringing up this case and trying to get you all's opinion. So this variant has not been reported in literature in individuals affected with CTLA4 related conditions. Algorithm developed to predict the effector of the sequence changes on RNA splicing suggests that this variant may disrupt the consensus splice site. In summary, the currently available evidence indicates that the variant is pathogenic, but additional data needed to prove that conclusively. Therefore, this variant has been classified as likely pathogenic. And then, as I mentioned briefly about the other variants as well, our patient did not fit into those. So this, so majority of the mutations in the CTLA4 affect the CTLA4 extracellular domain on the exon. This is from an article published back in 2017, where it shows the mutations that are associated. And as you can see, it's mostly along the exons. Then it's just a small picture to show that this is where we are expecting. So intron 1 at the splice site, where the mutation in our patient is. So just few slides about what CTLA4 is. Cytotoxic T lymphocyte associated antigen 4. It's a transmembrane protein expressed constitutively by regulatory T cells and induced on activated conventional T cells. So here's a good depiction of how it works. So it essentially competes with the CD28 for the binding of CD86 and 80, as you can see in this picture. If it doesn't bind, the T cell gets activated. If it does bind, it leads to the inhibition. So thus it restricts the co-stimulatory effect of the CD28. Then looking at the second one, it has so the endocytic function, which actually results in removal and lysosomal degradation of the CD80 and 86 from the surface of APC. So here you can see the ligand. So it takes that, and then within the lysosome, it breaks down. And then the CTLA4 itself is recycled. So that's the transendocytosis process. So all in all, it leads to the inhibition process. So CTLA4 is an important immune checkpoint that modulates tolerance, and CTLA4 pathway engagement promotes the Treg suppressive function, like I mentioned. Its blockade enhances T cell activation. In the absence of completely functioning CTLA4, autoimmunity ensues. So like we saw in our patient. And then there is, in the mice model, CTLA4 deficiency has caused lethal early onset multi-organ autoimmunity, demonstrating the dominant role of CTLA4 in the maintenance of immune tolerance. So just to go back, since we talked all about CTLA4, this is the mutation that was seen in our patient. What should we do next now? And this is where Dr. Ibrahim is going to help out. And she actually ran this. We are very thankful to her. She ran through some of the classification tools this variant, and she mentioned that this is consistent, or the score that we got, that it is consistent with pathogenic. So I think she would shed light on this more. I have few slides about what should be done in future with this patient, or what testing should be done.
Yeah, so I think, Adil mentioned that in his official report, it said likely pathogenic. In this particular modeling program, the ACMG score is 10, which is consistent with pathogenic because it's got a null effect in a gene where loss of function is an issue, which we know to be the case with CTLA4. There are a few different splice predictors that we use to look at it. You can see the effect on splicing. So coupled with the phenotype, and then I think Adil may tell you whether he's done quantitation of Tregs and looked at CTLA4 expression or not. Adil, do you?
Yeah, so we haven't gone beyond the genetic test yet, but this is something we are going to be doing, and I think you sent us this, that there are two ways to go about it. One, this article was just published last month, where they mentioned the CTLA4 dependent transendocytosis, like we saw in the slide earlier. So here they can check the function of CTLA4 dependent transendocytosis.
Actually, we can come back to this slide. Do you have the other slides? Let's see, what's your, yes. So I just want to make a point that the transendocytosis assay is not a clinical assay, it's a research-based assay because it requires the use of that plasmid with either CD80 or 86 with a fluorescent label. And so there are some poor man sort of alternatives. One is, of course, quantifying Tregs. and looking at surface versus intracellular expression of CTLA-4 in unactivated, in just regular Tregs. It's not the ideal assay because if you just look at expression alone, there may be some particularly missense variants in CTLA-4 that can dodge the antibody we use to look at CTLA-4, the BM13 antibody. So this is an assay where we look at upregulation of CTLA-4 after activation of Tregs. So here, basically, you're seeing gating on total CD4, gating on CD4 positive FOXP3, and basically you're looking between the resting state and the activated state and upregulation after you stimulate Tregs overnight with anti-CD3, anti-CD28 co-stimulation. So you can see that the black represents the resting, the red is activated, and you see this sort of nice upregulation of CTLA-4. We're looking at median fluorescence intensity. Here's a patient with the CTLA-4 variant, the arginine 70 tryptophan, and you can see that there's absolutely no upregulation of CTLA-4 on activation. Then you might ask, well, then can this be used as an alternative to the transendocytosis? Yes, for poor people. When you don't have access to the transendocytosis assay. But there are some cautions to keep in mind, and that is it can be highly variable in healthy controls, and that's why we, in addition to using an experimental control, we try to look at the data from multiple healthy controls because of that variability. So obviously the transendocytosis assay is the absolute gold standard, and looking at quantitative Tregs, looking at surface intracellular in regular Tregs, that means resting, not activated, and then looking at the CTLA-4 upregulation gives you some sense if you don't have access to the transendocytosis assay. Just a point I wanted to make regarding this paper from the Grumbacher group compared to the earlier studies of the transendocytosis assay, which use green fluorescent protein for CD80 and 86. So I think what's attractive about this is they made a new construct in CHO cells with a new dye or a new fluorochrome, M-scarlet. Why is the M-scarlet more advantageous than the GFP? So when the Tregs pull down the CTLA-4 with its B7 burden, it goes into the endosomal and lysosomal compartments which have acidic pH. The acidic pH is not very favorable to the green fluorescent protein. It tends to destabilize it. The M-scarlet is much more robust and can withstand acidic pH. And that is why you see this difference in that line graph that you can see way over on your left. You see the difference, the magnitude of difference in the percent and even in the MFI between the GFP and M-scarlet. So I think this is a wonderful reagent that has been developed. The only catch is that, these sort of research reagents are very tough to validate in a clinical laboratory. They don't, they're harder to meet the regulatory standards. So that is why, if you go to the next slide, we use that sort of combo of, a few different things to sort of compensate for the lack of having a transendocytosis assay. The one other point I would make is that the M-scarlet, the M-scarlet CD80 is also stable in frozen versus fresh PBMCs compared to the GFP. The GFP shows a lot of variability in frozen samples, whereas the M-scarlet is quite stable. So that's yet another reason why that particular marker, that particular fluorochrome, that particular reagent is much more useful in the transendocytosis assay. Now, the transendocytosis assay can also show some considerable variability depending upon the variant. So, while it is the best assay available because Treg suppression assays are challenging, you have to then, put it again in the context of quantitative Tregs, clinical phenotype, and the rest of it.
Wonderful. Now, they are asking a couple questions regarding more for the patient specifically about her autoantibody profile. So that is something this is a case that we actually started working on, like for the first time seeing her about 3 weeks ago. So this is something that we definitely need to pursue, getting the records from the previous providers. But we know for a fact that she's had multiple blood transfusions because of severe anemia, and somebody mentioned before the potential for Evans syndrome. We don't have any particular history of any other line being compromised, but it's definitely something that we would need to consider. Yeah. They were also asking about a potential like mouse model to test for like immune system and autoimmunity. So is there anything you can comment about this, Dr. Abraham? Like,
it's not easy, right, to sort of recreate a mouse model. It takes a lot of work, a lot of money. Certainly, you know, people with access to research labs and funding can afford to do that, but I think that's out of the reach of most clinicians. And if you're trying to make rapid decisions for medical management, that won't really help. And some of these sort of assays, you know, would give you faster results than you would with any of those other sorts of assays. And just a point that I think Andreas made about Treg lymphoproliferation. So he's talking about a Treg suppression assay. So basically suppression of proliferation when you've got an effector plus Treg combo. It's a very challenging assay to do because in terms of numbers of cells, particularly if you have babies or children to sort out the appropriate. And so no clinical lab has really standardized Treg suppression assays. And I've tried it, but it's just very technically challenging. But I think if you do, again, a combo of the quantitation, the surface intracellular, the upregulation, it might, you know, and you have to keep in mind there's also incomplete penetrance of about 40%. So, but it might, you know, give you something fairly quickly in a matter of, you know, 3 or 4 days to give you a result to let you know which way the wind might be blowing and whether you might want to consider some of that in terms of selecting your management.
wonderful. Well, this is basically the point where we are with this case, and this is hopefully what we can pursue to
Juanita, there's one more question about whether the patient received abatacept.
Oh, I apologize. I had not seen that. Not yet. She has not received it, but definitely something we're considering. Basically, like we were awaiting or are awaiting more of like functional testing, although her clinical picture is quite convincing, and the patient is on board for us trying what would we consider more appropriate. So not yet, but something we are definitely considering. Right. Thank you for mentioning that. The family members. So this patient has one daughter, and she has actually, perhaps we didn't mention that, she has had recurrent miscarriages, but she does want to have more children. So this is something that definitely is worth looking into her family members, if anybody else has a picture like that, or even in her parents. Thank you, everyone for their contributions, their questions, their comments. It's been wonderful, Dr. Abraham. It's been amazing to share with you this time. Thank you for your generosity, and thank you everyone for participating tonight. So if you have any further comments or questions, please feel free. We still have a few more minutes that we can share with and kind of like grab the last few minutes of Dr. Abraham's expertise and all these things that she has taught us tonight. Well, they're mentioning how much they learned. I think we all learned a lot tonight, and we appreciate everything that you guys shared. Thank you. Thank you again for joining us tonight. And we hope to see you in next month's webinar. And this, as they are mentioning, as Sarah is mentioning, this is being recorded, so we can go back and review all the good things that we learned tonight. Thank you so much.